Welcome to the Veterinary Rehabilitation Podcast, where we aim to help fellow veterinary rehab therapists increase their knowledge and elevate their practice. I'm Megan Kelly.
And I'm Ane Lloyd. Together, we bring you the latest insights, research, and information in the field of veterinary rehabilitation.
This podcast is brought to you by Onlinepethealth, a leading continuing education membership for veterinary rehabilitation therapists. With Onlinepethealth, you'll have access to a wide range of online resources to help you stay up to date with the latest techniques, advances, and trends in the industry.
Our podcast features in-depth conversations with leading experts in veterinary rehabilitation. They share their own experiences and knowledge to help you improve your practice. Whether you're a seasoned pro or just starting out in the field, our goal is to provide you with the tools and the insights you need to succeed.
So join us as we explore the exciting world of veterinary rehabilitation and help you take your practice to the next level. Hey vet rehabbers, in today's podcast, Mike Farrell and Ane Lloyd dive into the topic of using Librela for canine osteoarthritis. They specifically focus on how rehabilitation goals and considerations can be affected by this treatment. The discussion covers various aspects, including the impact of rapidly progressing osteoarthritis, nervous system side effects, as well as the efficacy and dosing of Librela. Now, if you are on Facebook, please come and join us on our online communities. We have the Small Animal Vet Rehabbers, Hydro Vet Rehabbers, Equine Vet Rehabbers, and our Business Vet Rehabbers. Now, this is where the Vet Rehabbers hang out online. We share research, tips, and advice, and it's a really great supportive community. We would love to have you online there with us. Before we carry on with this chat about Librela, a quick word from our sponsors, Curacao Vet. Curacao Vet is owned by Nada Robinson. She is an integral part of our community. She's always so supportive and always keen to sponsor education and learning for our vet rehabber community. Nada first developed her courses at the Colorado State University, where she started the Medical Acupuncture for Veterinarian Certificate program, and this was in 1998. In so doing, she also developed a science-based platform for veterinary acupuncture, which was the first of its kind. Today, Curacao Vet offers a comprehensive curriculum in integrative medicine with a rational evidence-supported foundation. She has courses such as medical acupuncture, photomedicine, botanical medicine, medical massage, and integrative rehabilitation. You can discover Curacao Vet at curacao.org. Right, over to Ane and Mike.
Hi and welcome. Hi Mike, thank you for joining us.
Thanks for having me.
Awesome. All right, so Mike, can you please introduce yourself and let us know what your interest is in Librela?
Right, yes. So I'm Mike. I go by Mike rather than Dr. Farrell, and I'm a board certified specialist in small animal surgery. I started my career in veterinary anesthesia. So I also have a certificate in veterinary anesthesia and a special interest in pain management, in particular chronic pain management. Every talk about a painkiller has to start with a disclosure of conflicts of interest, and my disclosure is that I have no financial conflicts of interest. I'm not linked to any drug companies, supplement companies, or nutrition companies. So yes, my interest in Librela is sparked by the fact that I'm interested in companion animal pain.
Awesome, thank you. All right, so let's talk about what Librela is. I'm sure I'm not the only one who doesn't have any exposure to this drug yet and doesn't know why it's being used or prescribed or why it's making such big waves. So what is Librela and how is it being used?
Well, I like to explain things using analogies, and the analogy that I will give today, it's a new one for you. I gave another one last week. Is about pain, which is a noxious stimulus, being like an unpleasant sound. So we start with this. We've got this noxious stimulus with unpleasant sound. Now, acute pain, that's like somebody scraping their fingers down a blackboard. And you know that when they get to the bottom of the blackboard, the pain will go away. The noise is going to disappear. There's an end point to it. So your job, while this noxious stimulus is there, is to either turn down the volume on the pain, stop the pain entirely, which is possible with some kinds of painkillers, or to ignore the noise, But what you do know with acute pain is it's going to go away. You've just got to sit it out somehow. And chronic pain is like an unpleasant song which is playing on loop over and over again. There's no off switch. You can't turn it off. So your options in managing chronic pain are to pretend it's like acute pain and try and turn down the volume and hope it's going to finish, but it never will. Or you try and get rid of the music at the very beginning. So you try and get rid of the actual music, or you put earplugs on, something to drown out the noise. So the traditional painkillers that we give, things like non-steroidal anti-inflammatory drugs, opioids, etc., they turn down the volume on pain, and nerve growth factor acts like earplugs. It's something to muffle out the noise, right? So that's the mechanism that we're talking about. How it actually works is that it's a drug which mops up a chemical called nerve growth factor. So nerve growth factor acts all over the body. It acts specifically in some certain types of nerve cells which are responsible for sensation, but it also acts in all other cells all around the body. So not just nerve cells, but in cells in bone, in cartilage, in skin, in white blood cells. So it's all over the place. And Librela's job is to mop up this nerve growth factor so that it doesn't cause problems within the body, which are related to too much nerve growth factor causing pain.
Can you describe the role of nerve growth factor in the body a little bit more deeply? What is its job and why is it there?
So it has, it's called pleiotropic, which means it's got multiple jobs, not just one. So when you're growing, it has a job to tell the nerve cells to develop. So it's absolutely key in developing of nerves. And then once you reach adulthood, its job changes to protecting those nerves. So it develops a maintenance function. So it protects them, it encourages nerve growth, and if a nerve is injured, it helps that nerve recover from the injury. So its main jobs are related to nerve function, but it has all sorts of other different functions as well. For example, functions in bone turnover, functions in cartilage turnover, functions in immune function. So lots of different jobs within the body, and those jobs carry on throughout life.
Okay. So what happens if we block the nerve growth factor? And does Librela block it completely, or does it just reduce its amount? What is Librela doing to the nerve growth factor in our bodies or patients' bodies?
Yeah. So the nerve growth factor acts on a couple of receptors. One of them is called a high affinity receptor, which is called a tyrosine kinase receptor. It binds onto that receptor, and then it tells the nerve cell to do a job, or any cell to do a job. So when we give an antibody to that, what we're trying to do is mop up the excess. We're trying to allow enough for it to do its essential job, but not too much. The parallel that I give for that is non-steroidal anti-inflammatory drugs. So non-steroidal anti-inflammatory drugs, we've got an essential process, which is inflammation. If we don't have inflammation, we would die. But too much inflammation causes a problem. So what they do is that they suppress a type of cytokine called cyclooxygenase, just suppress that cyclooxygenase just enough so that we don't have too much inflammation, but we've got enough to survive. And that's what Librela does. It suppresses the nerve growth factor just enough, ideally, so that we don't have side effects, but we do have effects. Now, if you completely knock it out in an adult, which is what was done originally in the early studies in rats, so you completely knock out nerve growth factor, it will make those animals ill. So in rats, what they were seeing when they completely knocked it out was that they saw problems related to learning. They saw problems related to nerves. That is, that the nerves got smaller and lower in number, some of the important sensory nerves. And there were immune problems in those rodents. So we want to suppress it, but not completely knock it out.
Okay, that's really interesting. What you spoke about the early studies of Librela now. How long has it actually been around, and what is its evidence basis at the moment?
Yeah, so a longer time than people think. The initial application for an experimental drug license is 20 years old. That was 2004, when Pfizer applied for a license for a human version of the drug called tanezumab. Then clinical trials are done initially on experimental animals. So it starts with rodents and then moved on to humans. In people, the first clinical trial, which was a randomized controlled trial, was published in 2010, and that was for osteoarthritis. 2011 was the first study to treat lower back pain. And then there was a hold on clinical studies, which lasted 5 years long between 2010 and 2015. No one was allowed to do clinical studies during that time because of concern about side effects. Then the studies restarted in 2015, and then the veterinary products had some more studies done on them in actual clinical patients. And those studies were published within the last 3 or 4 years, 5 years. So yeah, we got an evolution of studies starting with experimental animals, then humans, and then clinical trials in dogs for Librela or Baranza in Australasia, and then in cats for a similar drug called Solensia.
Okay, so what are some of those side effects that showed themselves and stopped the clinical trials?
Okay, so the side effects that stopped the clinical trials in people were two types of side effects. So the first hold was put on for a problem called rapidly progressive osteoarthritis. And the second hold was put on for autonomic nervous system problems, so sympathetic nervous system problems. So rapidly progressive osteoarthritis was happening, depending on the trial, in anywhere from less than 1% of people to, in some trials, over 6% of people were developing this problem called rapidly progressive osteoarthritis. They saw a significant increase in people needing joint replacements that were having these drugs. And we're talking about a lot of people in these trials. There's over 10,000 people that have been involved in these trials, much, much bigger trials than in veterinary medicine. That was the first one, rapidly progressive osteoarthritis. And then the second one was autonomic nervous system problems, which is the part of your nervous system that is controlling your everyday functions. You know, it's critical functions like your heart rate and rhythm and your breathing and your digestion and your urination. They're all controlled by the autonomic nervous system. So that hold lasted 3 years. It was put on initially because of concerns in rodent models. As I mentioned to you before, these rodents were developing problems related to their nerves, smaller nerves, fewer nerves, and learning problems. Then they repeated the studies, but they did them in monkeys. And then they said, actually, this is not a problem. And the FDA and European Medicines Association accepted that they would restart, but there was a caveat put on that everyone who had any suspicion of a sympathetic nervous system problem was excluded. You're not allowed to go into a trial.
Okay, so is there a connection between a pre-existing nervous system problem and then developing side effects with Librela? And has that been in the next series of trials? Were those effects eliminated by removing that group of patients from the trials?
That's an extremely good question. What they did in people, which was starting in 2015, was that they have very strict guidelines as to how to pre-screen people for any kind of sympathetic nerve problem. So if you've got a heart rhythm problem, for example, you are not getting on the drug trial. If you've got a problem which seems like it would be minor to us, like a bladder problem, if you've got urinary incontinence, you're not going on that trial. Then there's a system where you can do a survey. Anyone can do one of these surveys, and you can look them up. I wrote the name down. It's called the Survey of Autonomic Symptoms. It's got 12 questions on it. A survey of autonomic systems. You run through those questions, and the maximum score, which is the worst possible score, is 60 for a man. It's lower for a woman because in men it includes can you get an erection, and then if you get higher than 7 out of 60, you're not getting the drug. Wow. There is no veterinary equivalent, because in the veterinary trials, which were very much smaller, the veterinary trials, although there were some kind of problems related to nerves, they happened infrequently and they seemed to be milder, and they weren't considered something that warranted those special precautions. Nevertheless, taking precautions is a good idea.
Yeah. Okay. So in animals, we don't have that same screening process, but the side effects that we see are also not as severe. Is that right?
Another very good question. So the two big ones that cause problems in people, what we're talking about, the first one, rapidly progressive osteoarthritis, that's the reason that it didn't get a product license. So that was outright rejected in 2021.
Okay.
And then the drug's basically been dropped. There's no new registered clinical trial since then. That's rapidly progressive osteoarthritis. Now, in order to know if somebody's going to have rapidly progressive osteoarthritis, you have to take multiple x-rays in series. So that was part of the testing. Take an x-ray at the beginning, keep taking x-rays over and over again and see if you get a problem. That wasn't done in dogs. So in dogs, one of the trials, which out of 3 that we used to get a license, used experimental beagles, took some x-rays at the beginning, took some x-rays 6 months later. The results of the trial published last year said, we didn't identify rapidly progressive osteoarthritis, therefore dogs don't get rapidly progressive osteoarthritis. But the analogy that I gave is it's a little bit like trying to predict the end of the score at the end of a game of football, rugby, American football, having watched the first 5 minutes of the game, wearing shades. They didn't look very hard for this problem, so they can't say it doesn't exist.
So do you think that the evidence that we have that supports its use for dogs, is it sufficient?
Well, it's not. You keep asking me questions.
I mean, can we rely on that evidence? Or essentially, should we say, hey, we need better evidence here? This isn't good enough. Can we ask better questions?
So that's an excellent question, right? So it's the same organizations that make the decisions. It's the FDA and the EMA that make the decisions for people and the decisions for animals. They looked at higher quality evidence for licensing in people than they did in dogs. There were far more people. They looked harder for conditions. It was a much stricter process. And they said no. But when they went through less strict process for animals, they said yes. Now, how you look at that depends on your perspective. Now, from my perspective, I look at it as being a benefit to us because we have a drug that is a very, very good drug, a very powerful painkiller. If you use it in the right circumstance, it can be life-changing. And I would rather have it than not have it. But having it on the shelf and saying, this is a drug which is completely free of side effects, I don't think is a fair thing for us to do. I think we have to say, we've got a really good painkiller. Just like all really good painkillers, it has side effects. There's things we don't know about it at the moment, and there's things that we have to keep looking for. So that's a long answer, but that's my answer.
No, I mean, I do love that because as a veterinary physio, you know, we love to say we're using evidence-based practices and techniques. And the truth is that not all of them truly are, because the evidence that we have small sample sizes. They didn't necessarily look at all the different variables. However, it's very different when we're looking at a drug versus a technique that we're using and then reevaluating as we go, and where the side effects are not necessarily serious. We might have a little bit of an increase in pain, or we might not achieve our goals, right, of strengthening or pain control from a physio perspective. So it is quite different if we're looking at a drug. But I always like to question, you know, if we're relying on the evidence, are we actually relying on good evidence, or are we just saying it because it's nice? There's been clinical trials and they were good and the results were positive, so we're using this. So, okay, no, I think that's a really good answer. And you've highlighted that this is a tool that can be incredibly valuable. So can you go a little bit more into that? As I understand, Librela is primarily being used to treat arthritis. When is it used for arthritis? Which are the patients that it should be used for? Talk a little bit more about what its clinical, when do we want to use it?
Yeah, okay. So I guess we have to sort of set our base rate. That is the problem that we're treating. And the problem that we're treating is specifically osteoarthritis. Mm-hmm. We can move on to off-label use if you want to. But if we talk about specifically osteoarthritis, our base rate is that we think about a quarter of the companion dogs in the world have clinically important osteoarthritis. So as an example, let's just look, because it's convenient, at USA alone, the numbers in the USA. So about 100 million dogs in the USA. Quarter of them have clinically important osteoarthritis pain. 25 million dogs have osteoarthritis pain. Of those 25 million dogs, half of them are untreated. They don't have any treatment at all. So we've got, in the USA alone, 13 million dogs with clinically important osteoarthritis pain. Why are so many dogs untreated? Well, there are lots of different reasons, but one of the reasons could be that people are intimidated by painkillers. They don't want to give a painkiller for fear that the side effect of the painkiller is going to be more important than the effect of the painkiller. Yeah. But we have to see what it's doing to the dogs. And if you look at it purely in mortality, about 1 in 10 dogs in a British survey ultimately lose their lives because of osteoarthritis pain. That's just osteoarthritis. We've got other types of pain too. So our base rate is a serious problem. And we have a lot of dogs that cannot tolerate non-steroidal anti-inflammatory drugs. We've also got problems with compliance of giving those drugs. You know, you have to remember to give a drug once or twice a day. So Librela as an alternative has some appeals to it. It's relatively cost effective. It's a powerful painkiller. We can go into how powerful in a moment. It's quite convenient. And for many dogs, it appears to be very, very safe. The side effects that we're talking about seem to happen relatively rarely. We've got to remember, in Europe alone, in the first 2 years, about 4.5 million doses have been shipped of this drug. So, you know, this is a drug which is very popular. It's being used a lot. So we have to put things into context. Now, how powerful a painkiller is it? Well, in people, it's about like for like with non-steroidal anti-inflammatory drugs. They're about equivalent to one another. What tends to happen is that the nerve growth factor antibodies get off to a faster start. So when you give it after a month, you get a more profound initial effect. By 4 months, it's way ahead compared to a non-steroidal. And after that, they kind of join up. And in the long term, they're similar. So the first type of animal that it's good for is one where you can't use a non-steroidal. Yeah. And then the second one that it's good for is an animal that's you're using a non-steroidal, it's not giving enough pain control, and you need to add something else on top, which is another conversation. But we have to be a bit careful about using it as a blanket painkiller for all animals. And we have to look out for the animals where maybe it's contraindicated.
Okay, so primarily we're using it for osteoarthritis, and we're using it when non-steroidals are not an option, or when we need an additional on top of the non-steroidals. So those are the indications. What are the contraindications? We're screening our patients. When do we not want to use Librela?
Okay, well, according to the data sheet, don't use it in animals who are under 1. It's only licensed for osteoarthritis pain. So it's not indicated to use for other types of pain, but we can still have a discussion about that because it often is. So those are the official contraindications. We've got young animals. Shouldn't use it for pregnant animals. That's always one of the contraindications, just about every drug, and we shouldn't use it off license.
Okay, so off-label use. Do you want to touch on that, because you've mentioned that there are more spaces where we might want to use it? So what would those be?
Yeah, this is where it becomes quite difficult. Talking about off-label use, and in lots of different ways, it becomes difficult. You've got this idea that pain is pain. All pain is important. And if you've got a painkiller that's capable of treating any type of pain, why not use it for any type of pain? And it has been successfully used to treat low back pain in people. It didn't get a license for that either. And it seemed to perform worse in people to treat low back pain, in part because in a person, osteoarthritis pain, we've got mainly 2 types that were treated: knee osteoarthritis and hip osteoarthritis. Mm-hmm. They are homogeneous conditions. They're quite predictable. One arthritic knee is a bit like the next arthritic knee. One arthritic hip is a bit like the next. Mm-hmm. So you kind of knew what you were getting. But with, as you know, as being a physio, low back pain has got many different aspects to it. Yeah, you've got discogenic pain, you've got muscle pain, you've got articular facet pain, and then you've got all these other things that go in that area which contribute to the pain. And it seemed that all of these different types of pain responded differently to drugs in the class of Librela. So the responses seem to be unpredictable. But what they concluded it was that the side effect profile of it didn't justify the benefit. That was that the side effects were much the same, whether you had low back pain or osteoarthritis pain, but the benefit of it was relatively smaller for low back pain. The challenge that we have with animals is that if you've got an animal who's got pre-existing problems of nerves and you give this drug, could it worsen the problems of their nerves? Take, for example, a dog who's got degenerative myelopathy. The beginnings of a German Shepherd dog with degenerative myelopathy. That dog is going to need all its nerve growth factor, because the nerve growth factor's job is to safeguard what they've got left of the nerves that are working in their back. So in principle, if you give something which suppresses those nerves that are trying their best to hold everything together, then you could make their neuropathy worse. And now this is something that's not been, this is a theoretical thing. It's not been proven, but at the moment, we're collecting data. This is called phase 4 clinical trials to see, are these things happening out there when we've got bigger numbers of animals that are being treated? So I encourage people who are seeing a dog, whether you're a pet owner or a physio or a veterinary surgeon, if you have a dog who's seems to be getting worse with spinal problems, that they're on Librela, you have to ask, could the Librela be contributing to that problem? And it's in the same way as if you had a dog that was on non-steroidals and they started being sick or having diarrhea, you would stop the medication first, regardless of whether it was the cause, and then make a decision about what to do next. It should really be the same with Librela. If you've got a side effect that might be related to the drug, you should ask, is it? And if it might be, proceed with caution.
Okay. No, that makes sense. You stop what you're doing, evaluate what could be the cause, and then reintroduce pain management from there once the symptoms or side effects that you're concerned about are under control and dealt with, right? So you mentioned them NSAIDs and Librela being used together. do we have studies, and you describe that kind of rapid improvement on the Librela with a slower improvement on NSAIDs, and that comparison? Do we have direct data that compared the use of NSAIDs with the use of Librela in an OA model? Do we have that?
Yes and no. So in the studies that were done in people, which is bigger scale studies, one of the big concerns with rapidly progressive osteoarthritis is that it was significantly more likely if you took a non-steroidal anti-inflammatory drug at the same time.
Okay.
So there are different hypotheses for why rapidly progressive osteoarthritis happens. So the one that everyone should be able to understand is if you lose the ability to sense where a joint is in space, if that joint seems to be relatively numb, then you load it differently, right? In the same way that if you couldn't feel pain in your hand and you touch something hot, you wouldn't know you touched something hot and you'll damage your hand. So that's one of the reasons why they think that rapidly progressive osteoarthritis might happen, because it works so well that it means that you can't sense where your joint is in space and you load it abnormally. But the second reason is that it actually changes something physically within the joint. And so one of the things that nerve growth factor is involved with is bone turnover. So it's got an important role in telling bone to keep turning over, repair yourself. And so do non-steroidals. They're involved in that process as well. So the second hypothesis is that if you give the two together and it interrupts bone turnover, you're actually incapable of healing little tiny microfractures within your joint, and then the joint starts to collapse. So when the two were given together, a much higher chance of seeing this rapidly progressive osteoarthritis. Now, the problem in animals was that in the trials where they gave non-steroidals, in those healthy beagles, they only gave the non-steroidals for 2 weeks. Okay, so it's not really long enough to that's not a fair test, right? When you only give them for 2 weeks. Some of the dogs in the field trials were given non-steroidals as well, but they didn't look for rapidly progressive osteoarthritis in those animals. And then one of the papers that I summarized on the Facebook page, Vet Lessons on Librela page, that's I just put out a few days ago, was about a study in rabbits. And in the study in rabbits, they created an unstable knee joint. They sectioned their meniscus, so they got an unstable knee. Then half of the rabbits get equivalent of Librela and half of them don't. And then they looked at what happened to their knees. And in the rabbits that had the Librela equivalent and the unstable knee, they had very rapid progression of osteoarthritis compared to the other ones. So if you've got an unstable joint, or you're giving a non-steroidal at the same time, then potentially there's an increased risk of progressing the osteoarthritis. You pay the price for your better pain control by more accelerated arthritis. But this is a discussion which isn't based on the field trials that were published to get a license in animals.
Okay. Yeah, that's definitely something to think about. Way up the scales a little bit. Okay. So right now it's being used in dogs. Lots and lots of it is being used and prescribed. You mentioned that it's convenient from an owner's perspective. How is it administered?
So it's given as a subcutaneous injection. It has been given initially as an intravenous injection. Then when they changed it to subcutaneous injection, they found that it had similar effects. So that made it more convenient to use. Initially in people, it was given every 2 months, and in people it's every 2 months, and in animals it's given every month.
Okay.
Interestingly, there's quite a big dose range. So 0.5 to 1 mg per kg. Now, there's plenty of evidence out there that the side effects are related to dose. So the lower dose seems to have lower side effects than the higher dose. Now, the way that it is dosed, and this is kind of a practically very important thing, is not that scientific, in that you take a vial. There's a chart that you look at and you say, well, this dog needs this many vials, and there's a big range. So if you've got a 30-kilo dog, you're going to give a 15 milligram vial. That's half a mg per kg. If you've got a 30.1 kilo dog, you're going to give a 20 milligram vial. Your dose has jumped right up because you're in the next category. So one of the things that I would encourage people to do is actually give the calculated dose, 0.5 mg per kg. You can increase the dose later, but if it were me and my dog, I wouldn't do it according to a chart. I would give them the measured dose at 0.5 mg per kg.
Okay, and that's a subcutaneous injection once a month. I mean, yeah, that's pretty convenient. From an owner's perspective, it's not a daily thing, but it is a monthly thing that has to be added into their schedule, where they need to go in and see their vet, which could be very good because it gives that opportunity to monitor the progression of OA on a monthly basis. So with these patients that are right now receiving Librela and on it, how are their responses to treatment being monitored? How are side effects being monitored? Are they being monitored, reported, taken back to Zoetis, who's created the drug? Is there a process going with that?
Yes, there is. There's a reporting process. So the first question is, how do we know how well it works? You can either kind of do what everyone does, which is to say, my dog seems to be better. They seem to have better exercise tolerance. It's not very scientific. And now something interesting happened in the 2 field trials when they did this. So in the field trials, they were almost exactly the same design. One of them was done in Europe and one of them was done in the USA. And interestingly, the results were actually quite different, because the people giving placebo in Europe were about half as likely to see a benefit from the placebo than the people giving a placebo in the United States. Okay. And the moral of the story there is that when you really want your animal to be less painful, whatever you give, you're going to look for the good in it. Now, Librela is a powerful painkiller. It's proven a powerful painkiller. We've got to watch out for people thinking that things that aren't powerful painkillers are. So a placebo, a saline injection, was seen in the US studies. 37% at one point said, my dog's much better after receiving a placebo. So I would say try and be as scientific as you possibly can. There are questionnaires out there that you can fill in. Not necessarily CBPI. The most practical ones are LOAD. And the one that I use a lot, which is, I don't think, used enough, is the Helsinki Chronic Pain Index, has a catchy named Porsimer app. And Porsimer is really good. It's a little subscription fee, but it's super worth it. And if you're a vet, a physio, a pet owner, I would encourage you. I'll give you these graphs. You can chart the progress using Porsimer, and that will be quite an objective way of monitoring progress. Now, if you're seeing side effects, how you report those depends on where you live. Different countries have different processes, but you should report it. And my experience is that the reporting process is very straightforward. The drug company is very open and very helpful. People have got to remember the drug company, actually, they made all of their studies open access. Everyone can read their studies. So they're trying to be transparent, which is hats off to them for doing so.
No, that's fantastic. I was thinking about the canine metrology instruments as well. It would be really simple to say every month you come in for your injection, you fill out the questionnaire, we keep track of what's happening. And yeah, that doesn't take any extra time really from the veterinary practice. You just give the owner a questionnaire. I didn't know there was an app, or yeah, that's amazing. From the Helsinki Pain Index.
They're all validated. there's a lot of work done on them. There's similarities between them. But I like the Porsimer one enough that I pay a bit of money to subscribe to it. It's not very much money, but it's really practical. The challenge that we have with these metrology instruments is that they've been around for a long enough time. They're simple enough to use, but they're underused. Yeah. Really, we should all be using them all the time.
Yeah, I agree.
Yeah.
No, I agree. I think even for us as physios, I think it should be a part of our regular reevaluations. If you're, reevaluating a dog every 6 to 10 treatments, they should be filling out. The owner should be filling out a canine metrology instrument,
yes.
whichever one works for you in your practice, because there are a few to choose from. Cody is another one which is very simple. I don't think it's as complete, but it gives you the necessary information for the owner and for the dog. I think it's important as well when we're communicating with vets, when we're building those relationships. Here, I can show you some data plotted on a chart. I love it.
And of course, the other thing is accelerometers. And if I had a physio practice, I would be absolutely I would want every animal with an accelerometer. There are disadvantages to the quantified dog and the quantified cat. But I think the advantages for a painful animal of using an accelerometer outweigh any disadvantages. And it's the same, you've got an app and you can see the numbers. It's useful information.
Yeah, it's very useful information. All right, I think another question that I have about Librela is so you have spoken about a bit of a loading period where you're getting an increased response. Is there a tapering or a plateau that happens, or a habituation that happens to the drug where it becomes less effective? Do we see that at all with Librela? Yeah,
it's a very, very good question. So that the trials that were done to get the license gave 3 doses. And what they were seeing was an improvement across those 3 doses. So it says it in the data sheet. If you don't see an improvement after 1 month, be patient, because you might see an improvement after the second injection. But if you don't see an improvement after the second injection, you probably won't see an improvement. And then you kind of have to then ask, why am I not seeing an improvement? And that means going back to your physical exams, the most useful thing. It might be that the animal's got a dog's got cruciate disease, and if you see an animal with cruciate disease and it's subtle and you haven't picked it up at the beginning and you give Librela, what would you expect to happen? Well, if they've got subtle cruciate disease without much instability, you would expect their pain to improve, but their instability to get worse, right? Because you've done nothing to treat that. And as time goes by, you'd expect them to get worse. Same with the dog with maybe very lax hips. Their pain will improve, but the laxity won't. You'll expect them to get worse over time. So there should be a little alarm bell that rings to say, well, why is this not working as it should? Because osteoarthritis in dogs always has an underlying cause. You should go back to saying, what's that underlying cause? And is there another way of treating it? Then, of course, there's a long-term issue. So the long-term issue was that only 63 dogs completed a 9-month study. We didn't have a positive control group for those dogs. They were compared to nothing, because it wouldn't be fair to have, they didn't think it would be fair to have a negative control group. They didn't have a positive control group. So very small numbers had long-term use, and that was only 9 months. Now, the longest study in humans is 1.5 years, and what they saw was tapering, so that once you got to 4 months, that was your best effect, and then it tended to get gradually worse over time. And in the human trials, about half of the people actually dropped out because it wasn't working well enough before a year had passed.
Okay, interesting. So you're going to get to a point where it will probably taper, and then there's going to be the feeling of, well, we need to add something else, right? An additional drug to keep the pain under control or increase the dosage, right?
So I guess what you sort of have to think of you imagine your hands can't feel any pain, and you can't afford to touch those hot surfaces, that rule still applies all the time. You have to look at all those other things at the same time. It would be easy just to give this very powerful painkiller and then to say, well, great, that's doing all the job I need it to do. But you need to prioritize all those other things. And that means keeping your pet as lean as they possibly can be, regular checks with a physio. So physical therapy, super important. And then not just physical therapy in a clinic, but physical therapy at home. So all of those things remain critical the whole time. We don't just give a drug and forget about them. That's not what the treatment is about. Interestingly, by the way, I forgot to say before, in the surveys that were done of vets, it ended up being, one of the advantages ended up being that they used it as monotherapy almost always. So either it was so good as a drug that they said, well, we don't need any other drugs. You can give intermittently some non-steroidals and that's enough. So that is a good selling point, but that's just the drugs. The lifestyle things remain super important.
I love that you brought that up, because we like to forget that our pain management pyramid is built on a foundation of lifestyle changes, physiotherapy, education. Yeah, we forget that part.
Yes, but you know what? This is the crux of it. You've got lots of different ways to treat pain. And if you're given an array of different choices of how you're going to treat pain, you can pick the ones that you think are easiest or nicest or less expensive, and you can talk yourself into those things being very effective. The challenge that we have is that the things that work best aren't the easiest path.
No.
So, you know, going to a physio week after week, you know, ideally maybe twice a week, that's great. You should do it. But there's a cost entailed, there's inconvenience entailed. So people think, well, why would I do that when I can just give a supplement? Maybe that'll have the same effect. It won't. Or my dog needs to lose weight, but that means I have to give them less food. They love food. Why would I do that? You know, why do you do the things that are difficult when everyone's having you believe that the things that are easy are going to have an equally good effect? At the end of the day, the things that have the best effect are hard. You know, lifestyle management's hard. Weight loss is hard. Surgery is difficult. And a drug like Librela, perfect example. It's a good drug, but it's got negatives as well as positives. There's no free lunch.
I really love what you're saying, because I think, you know, we can sometimes feel frustrated when we have patients not referred to us because they've just been put on X, Y, or Z, or, you know, the vet recommended that course of action. But the reality is that it's what's easiest for the owner. And whether that is the vet's perception of the situation or the owner's perception of the situation, there's that shared idea that this is the easy path. And that's really powerful. That's really powerful for us when we don't have a lot of time, when we want to have good relationships with our clients, when we want to tell them what they want to hear. It's nice to tell them what's easy. It's really hard to tell them, hey, your floors are slippery. You need to make adjustments here. Your dog cannot jump in and out of the car. That stuff sucks. It really does. It's not fun. So I think that's really important. Another thing that you mentioned with the anti-nerve growth factor is proprioception and the change there. And I think this is something really important for us to understand, because if we have an altered proprioception as a result of a drug that our patients are on, how does that impact us? 95% of the time, one of our goals is to improve the proprioception of a specific area or of the whole body, because the moment there's pain, we have a change, an altered proprioception, and we need to restore that. So what is the impact of having these patients on Librela? How do we work around that in terms of proprioception? Because the benefit of any pain management, any pain control, is that we break that pain cycle. us as physios get in there, we improve their strength, their proprioception, their ability to functionally work with the condition that they have. And then we have an improved outcome that's no longer reliant on the drug, because we have taken some of the cause of the problem and reduced its impact. So can we still achieve that when Librela is blocking proprioceptive feedback, or are we fighting a losing battle then? How do we adjust our approach?
Nobody knows.
Okay.
I feel so bad because it's such a good question that you worded so well. And there, but nobody knows.
I mean, I think even if we just think about it, we need to evaluate our patients and have that in our mind. If we don't have the answer, that's fine.
Yeah, well, there's another guide that I put on the Facebook page, and it talks about neuropathies. And at the end of the day, in a perfect world, if a pet has a neuropathy, you would get a diagnosis first, right? You want to know what that neuropathy is, because there's lots of different types. You can't always do that, because the tests to find out what type of neuropathy it is, they're expensive often. MRI scans, etc., they're expensive tests. So what you end up doing is treating symptomatically. And if you're treating a patient with a neuropathy symptomatically, and you're giving nerve growth factor antibody at the same time, you are at cross purposes in principle. So if there's a known neuropathy, I think there should be an awareness to say, well, you might be treating a dog with osteoarthritis because you've got two problems at the same time, but you've got to consider that you might be making one problem worse in order to make the other problem better. And as physios, I think it's a matter of having the awareness that this is a potential problem, and feeding back to saying, if this is a problem that's getting worse, can we try, is there a way we can try without the drug? Now, if you've got a dog that's life is much, much better on the drug, well, sometimes you have to tolerate the side effect.
Yeah. That's, we make that decision or help our owners figure out that middle ground all the time. Sometimes we have to live with the consequences, but we have an improvement in some other areas. So no, that makes very good sense. And I need to wrap us up now because we're getting to an hour, which is far too long. Thank you so much to everyone who has joined us live. Mike, thank you for your time today. It's been really great having you. You guys are going to head over to Vet Lessons on Librela on Facebook if you want to learn more, if you want to dive into the research. It's a fantastic resource.
If you enjoyed this podcast, please hit the subscribe button so you get notified every time I load a new podcast. I'm here every week talking to vet rehab therapists from all over the world about all things vet rehab. A big thanks to our sponsor, Curacor. Their sponsorship allows us to be able to give this podcast to you for free. So please go and check them out at curacor.org. Don't forget to bookmark the next Vet Rehab Summit. It's on Saturday, the 31st of August, 2024. Come and be a part of the world's largest online veterinary rehabilitation conference created specifically for you, the vet rehabber community. Onlinepethealth members get VIP complimentary access to the Vet Rehab Summit. For more information about continuing education for vet rehabbers, you can go to onlinepethealth.com.